Thanks, Dr. Moss. That was great. There's a lot of overlap between these two procedures. Okay, so I'll be covering basivertebral nerve ablation now to kind of dovetail on the prior talks. Okay, again, it's the same acknowledgements. Okay, so I'll cover the indications. We'll go through a procedure overview. I'll talk about some of the outcomes data that's out there and a bit about prevalence as well. So again, the indication is vertebrogenic pain. So patients with moderate to severe low back pain as the dominant symptom should be present for at least 6 months, and there's no other suspected dominant source for low back pain. Patients must have motor changes, either type 1 or type 2 on MRI, and they must have failed conservative care. So that can be, there's no definition of that. It could be activity modification advice, physical therapy, exercise, chiropractic, cognitive therapy, prescription medications, injections. So this shouldn't be the first thing we think about with these patients, but if they failed other therapies, then this would be an option. Again, we don't have a diagnostic block for this in the same way that we do for other radiofrequency ablation procedures for the medial branch or sacral-lateral branches. So it truly is the clinical data. Contraindications, so this must be in adults. If there's imaging or clinical evidence of another etiology, so that could be things like spinal stenosis, instability, a disc herniation, posterior element pain, radiculopathy, those would be contraindications to do invasive vertebral nerve ablation. And osteoporosis or recent compression fractures or spinal tumor, just because we want to make sure we have good bone health when we're performing this procedure. And then our typical ones, local or systemic infection, implanted electronic devices for the radiofrequency procedure, and systemic diseases. Okay, our limitations. So in the US, the L3 through S1 levels are FDA approved, so they are approved to do this. This procedure can be done at L2 level. This would be considered for us off-label to do it at a different level than L3 through S1. Most that's because most of the studies that were done on this procedure were done at L3 through S1. No more than 1 or 2 levels at a single session. That's per CMS's Medicare, which covers a lot of the patients who undergo this procedure, and they couldn't have had a prior basivertebral nerve ablation. So this is essentially what it looks like. We have a trocar with a cannula, and this is the radiofrequency probe going in through the pedicle, so transpedicular access, and I'll go through that some more as well. So this is from our IPSIS technical manual. So again, this procedure can be done with fluoroscopic guidance. Transpedicular access is going to look very similar to what Dr. Moss just showed us for vertebral augmentation. We use an oblique approach to access the pedicle. The device that is FDA approved as an 8-gauge introducer placed into and through the pedicle under intermittent AP and lateral views. Once we reach the vertebral body, a curved channeling stylet is introduced through the cannula and advanced to the target zone. And then a bipolar electrode is inserted to the target zone and confirmed under those AP and lateral views. The standard lesioning protocol is 85 degrees Celsius for 15 minutes. So this is what it looks like. So under AP and lateral views, so this is our introducer, trocar. Again, there's that medial border of the pedicle here as we reach the posterior vertebral body. This is the channeling stylet insert into the vertebral body, into the central portion, here and here. Okay. And then that's now retracted, and now this is the radiofrequency bipolar probe, and that covers where we're going to be performing these lesions. I'll go through a little bit of technical considerations for this as well. So again, the target zone extends from 1 centimeter anterior to the vertebral body to its anterior limit at the anterior terminus of the basivertebral foramen. So at L3 through L5, this is going to be about 30 to 50% of the distance from the posterior to the anterior vertebral wall. So you can see this is placed slightly posteriorly. It's not directly in the midline from anterior to posterior. The target in the vertical plane from L3 to 5 is midway between the superior and inferior end planes. So this should be right in the center between superior and inferior end plane. A little bit different at S1, where the target zone is slightly more superior from about 40% of the distance from superior to inferior. Otherwise, the target zone is going to be very much the same. Okay, and then from yesterday's talk from Dr. Moss on lumbar spine anatomy, this will be a review of that. So again, from L3 to S1, the vertebral body becomes wider and the pedicles have a larger circumference with increasing obliquity. So you can see that increasing obliquity from L3, L4 to L5. So let's keep that in mind as we're planning our trajectory. At L5, again, the physician must avoid excessive medial or inferior placement to avoid cortical violation with the lateral recess being at risk if that were to occur. At S1, the iliac crest can also present quite a challenge and it can obscure an ideal trajectory. You can see how you need quite a bit of obliquity here. So pre-procedure planning is really imperative for this, so making sure that reviewing any pre-procedure axial imaging, MRI, CT, whatever it is available. Okay, this is from one of the basivertebral nerve ablation clinical trials where they looked post-procedure at MRI to see what the lesion zones look like. So you can see in the central portion of the vertebral body, this is how large the lesion is. So it is quite a big lesion that these bipolar probes are going to create within that vertebral body. You can see how that should capture that entire basivertebral nerve before it sprouts to supply the vertebral endpoints. So efficacy, there are two large trials that are often quoted to have positive outcomes. That's the SMART trial, which was sham-controlled, and the INTRACEPT trial, which was basivertebral nerve ablation against standard care, and that has 5-year follow-up. We also have a systematic review that was put together by the IPSIS Standards Division. So I'll go through that first. So this is from the IPSIS Standards Division, so used a great methodology to examine 7 papers on basivertebral nerve ablation. The criteria for success was at least 50% pain reduction, and what they found was 45 to 63% of patients overall had clinical success at 3 months, with 75 to 93% with more than a 10% ODI improvement. So not a huge result from the pooled studies. Looking at, there was one sham control study that I'm going to go into in more detail. You can see that the relative risk of success was fairly low, and I'll go through a bit of why that was. Whereas when you compare it to conservative care, which is also just really one study, over four times the relative risk of treatment success. So the conclusion from the systematic review is moderate quality evidence that this procedure is effective in reducing pain and disability in patients with chronic low back pain and type 1 or type 2 motor changes, which are the criteria for going ahead with this procedure in all of the studies that we looked at. So the SMART trial, so this was a level 1 prospective randomized, double-blinded, sham-controlled, multi-center clinical trial. They randomized patients 2-to-1, treatment over sham. For the sham, the trocar was docked at the pedicle only. Again, the patients were blinded to what they had done. There were 15 sites in the US, 3 in Germany. The follow-up was from 2 weeks up to 24 months. And again, standard inclusion criteria. So the results from that trial, go through this. So 147 patients in the treatment arm, 78 in the sham arm. Their baseline characteristics were about the same, ODI of 42, mean age 47, slightly more male versus female. And you can see these are truly chronic pain patients, so more than 3 years and 79%, 67% with at least 5 years of back pain. Okay, and the 24-month compliance, to point out, was almost 85%, so that's actually pretty good at 2 years. Okay. So this is the treatment arm and the control arm. So this is where it kind of gets interesting. So you can see there's, in the treatment arm, there's a change in the ODI of 20 points out to 3 months. And that's pretty good. But in the control arm, you also see a pretty significant change in the ODI, 15.5 improvement. So when you compare these two, the difference in their change in ODI doesn't really look very clinically significant. It's, again, it's only a 5-point or less than 5-point difference. So this is where you can see that, again, sham versus treatment arm, they both worked pretty well, but the treatment arm seemed to work better and was statistically significant in terms of improvement. So when we look at the treatment arm, again, per protocol, you can see that the results were quite durable. So if you look at the baseline ODI at 42, and the results go not just at 3 months, but all the way up to 24 months, you still see this lasting improvement. With the VAS scores also 6.73 at baseline, and continue to improve even at 24 months down to 3. So that's pretty impressive. In terms of opioid use, so opioid use was then also monitored for the first 12 months of the trial, and 26% of patients were using opioids at onset, and at 12 months, almost half of them had completely stopped taking opioids, and 14.3% had reduced their opioid use. The other outcome measure, secondary measure they were looking at was utilization, so specifically injections. So 57.5% of the patients had spinal injections during the 6 months leading up to the randomization, whereas afterwards, during the 24-month period, only 7.5% had received spinal injections for either new or continued pain. So a big change in terms of utilization. Okay, the second trial is the Intercept trial, which was, again, level 1, prospective, multi-center, open label, randomized. These patients were randomized 1-to-1 to the treatment arm of RF ablation with standard care. So they didn't receive a sham treatment, they received standard care, which could include, but was not limited to, physical therapy, injections, medications, manipulation. And these patients were, again, followed up out to 24 months, and then there's actually five-year data on this as well. Again, the same inclusion criteria, type 1 or type 2 motive changes, and kind of standard exclusion criteria as well. These are the baseline characteristics. So the average age was about 50 in both groups. Again, very similar male to female. And again, these are truly chronic patients. So 2/3 had more than 5 years of back pain. So these are truly chronic low back pain patients. Okay, this is where this one kind of gets interesting. So at the onset of the trial, there was a pre-specified interim analysis when 60% of patients were reached at the 3-month primary endpoint. There was an independent data management committee that met in 2019 to look at this data. And what they found during the interim analysis was that the primary endpoint and all secondary endpoints demonstrates statistical significance that were strongly in favor of the RF ablation. And as a result of how big the difference already was, the committee recommended that they halt randomization and allow early crossover of the standard care arm patients. So they effectively stopped this trial because there was such a big difference from the treatment arm to the control arm. So at the time of the interim analysis, 140 patients had been randomized. 104 patients at the primary endpoint were included in the intention to treat analysis, and there was, again, very small attrition at the primary endpoint. Okay, so this is you can see why this was stopped. So this is the difference in ODI change in 3 months. So in the RF ablation group, the difference in ODI was an average 25, and the difference in the standard care group was 4. So that's a big difference. So that's a difference of over 20 between these two groups. So again, strongly in favor of the basovertebral nerve ablation. These are some other characteristics. So patients who had more than a 10% reduction in ODI, almost 75% versus less than 1/3 in the standard care group. Patients with more than 20% reduction in ODI was 62% versus 13% in the standard care group. So very few of the standard care patients were having really significant clinical benefit from continued standard care. And then, again, these were the responder rates at 3 months using the intention to treat. So patients with more than 2-point BAS decrease was 72% in the RF ablation versus 34% in standard care. So when you kind of pool the two together, so Intercept and SMART trial, so this is the patients who received treatment. So the responder rates with more than 10% reduction is about 75% in both groups, and more than 20% reduction was 62% in the Intercept group versus 47% in the SMART trial. So both groups, and this is just looking only at the treatment group for both of them. 5-year outcomes, again, this is baseline, and then at 5 years, a reduction of 25 points in their ODI scores. So again, significant reductions in the treatment arms out to 5 years. So opioid use was reduced at 5 years, injection utilization still reduced at 5 years, 93%, and post-ablation procedures, only 8% of the patients who received the basovertebral nerve ablation procedure went on to getting fusion. And of the 8 patients who did go to fusion, 5 of them were at a single study site. So that may have been just the way that practice was, their standard practice there. This is a more recent study. I'm not going to include all the statistics from this. This is looking at that same cohort of standard care versus basovertebral nerve ablation out to 5 years, looking at cost effectiveness, quality of life, and they did find cost effectiveness demonstrated relative to the standard care group as well. Okay, what about prevalence? So, the procedure looks great based on all this data. Can we offer this to everyone? How many people are really truly candidates for this? So this group was at Vanderbilt University in the U.S. This was looking at essentially a retrospective chart review, looking at patients who would fulfill the criteria for basovertebral nerve ablation. So they had to have an MRI that showed motor type 1 or type 2 changes, and they also had to have the same clinical characteristics. So they looked at 338 charts, and of those 338, only 11 met criteria for basovertebral nerve ablation. So that's only 3%. So at least in this sample, it doesn't look like it's that common. But again, this is one group and one set of data here. So overall, basovertebral nerve ablation, the studies that we've looked at do show positive results. There are randomized controlled trials and real world data that does show success, and it does appear to be durable out to even 5 years. We'll learn about complications as time goes on, as the potential risks are very similar to the ones that Dr. Moss described with vertebral augmentation. Again, likely there's a low prevalence of this, but this does seem to be a real condition and can be distinguished from discogenic pain. I'll stop there. Thank you. I believe we have time for questions.